Floor is now open for questions as people are coming up or using the chat function. Maybe I'll just start with the Vibrant capsule. I think 100 years ago, people with constipation and various ailments used to go to spas and take the waters, and they'd have a masseuse who would massage their belly, and they had all these contraptions that would roll on you. And now we have, machines and gyms that, vibrate you. What's the advantage of taking, a pill that supposedly is going to be positioned cost-wise in a comparative fashion to medication, but we'll see, versus some other kind of external stimulation or other things? I mean, it's basically just vibrating in the colon, correct?
Yeah, I think that's a very good question. I think in terms of how they propose that this capsule is designed is that once it enters the colon, it delivers timed intraluminal stimulation, and whether or not that stimulation, particularly if it might be located in the right colon, has any meaningful difference in stimulating peristalsis over, generalized abdominal massage, I think is probably one of the basis for why it's believed to potentially be more effective, but that would be interesting to potentially do a trial with.
I'll volunteer for the
Yeah.
massage part. So, as other people are hopefully coming up, I'll ask you, Linda, a question about functional dyspepsia. And I think the vast majority of the patients that I see for EGD, and now it's an enormous number coming out after COVID, are people who should not be getting EGD if we were going by guidelines. And I'll make the exception that a large proportion of our population is not just Asian immigrants, but also immigrants from Samoa, Central America, other areas where there is a high incidence of gastric cancer, where maybe you might do a one-time endoscopy. But, for us, we'll have patients who are of Korean ancestry who weren't born in Korea, but they know that their relatives in Korea get frequent endoscopy because they do screening programs there, and they diagnose what we might call low-grade dysplasia as cancer, and they do endotherapy, and it's just a different deal. How do you propose that we fix this problem? Because I think if, EGD is pretty safe, it's pretty easy, but if we could use those resources to take care of our backlog of colonoscopy patients who are clearly going to have a benefit, I think we'd all be better served. Just thoughts on that?
I think that's sort of the holy grail that we all want to look at. Similarly, I think there are patients who come from high risk countries, like Korea, Japan, etc., or have a family history of gastric cancer. I definitely think that lowering the cutoff range. So in Asia, the Asian dyspepsia guidelines have the cutoff at 45. But that aside, kind of our, low risk dyspeptic patients, the challenge has to do with our reimbursement model. You get paid more for doing an endoscopy than having a conversation with the patient about what is functional dyspepsia, the diagnosis, the pathophysiology, treatment options, goals of care, goals of therapy, as opposed to, I don't know, you have these symptoms, they're vague, let's just do an endoscopy.
Yeah, it's a problem. Dr. Sultan.
One quick question. Do you use prucalopride for dyspepsia or gastroparesis? And is the mechanism maybe through the colon? That discussion that Mark Pimentel was saying, that if you have constipation, you're going to get gastroparesis? Or is there an interaction with the stomach itself that may help with those two conditions?
Yeah, so prucalopride has been studied in Europe for gastroparesis, and in their RCTs, it was found to be beneficial. In the U.S., it's not, you can't use it off-label. You can use it for patients with CIC. You'll find that about 60% of patients with functional dyspepsia or gastroparesis will have constipation. So you can use prucalopride to treat the constipation, which could help with both the gastroparesis or the prokinetic effects. But just simply treating the constipation often helps with their overall symptoms.
Thank you. Back microphone.
Yeah, hi. I practice here in New Orange County, and typically the patient comes in, I want something natural. to start with. Um, they are willing to do some meditation, nutrition, gluten-free, no problem, pretty good. Still, they have problems. So what are the concoctions that you start and then work them into other ones like not absorbable, and then finally the drugs? So this is a mindset that I see.
Is this a question for FD or for the lower gut?
Oh, for the for the lower, mainly for the lower, but hey, both of you can answer. Thank you.
Yeah, so you're saying that when you have patients who want to try kind of more natural therapies first, diet, maybe more mind-body based therapies. I find that these individuals usually are pretty motivated. And as long as you have a conversation with them about, well, if that isn't effective, what sort of pharmacologic therapy should be tried next. I do would at that point, if they don't respond to those initial, efforts, I usually do go to just initiating a pharmacologic treatment based on their predominant symptoms, whether it might be diarrhea or constipation. Again, the treatments that I choose would differ depending on what sort of bowel disorder they're experiencing. I'm not sure if that answers your question, though. Sorry.
Yeah, I mean, somewhat.
Yeah, so I can kind of dovetail off of that. So I practice in Northern California. So similarly, we have a lot of patients who want non-pharmacologic therapy. And the options there are, the diet and exercise. So there was a small study that looked at comparing yoga with hatha yoga in particular with a low FODMAP diet, and they were equivocal. So yoga was non-inferior to a low FODMAP diet. I think it's easier to do downward dog than to do a low FODMAP diet. So it's something that I do offer to patients. There's also the brain gut therapies, that is now more accessible. Historically, GI psychologists were at tertiary academic medical centers, but now there are there's virtual reality, there are apps, there are digital programs, both for cognitive behavioral therapy and gut-directed hypnosis. They're FDA cleared for IBS, so that's another option. Prakash mentioned earlier Iberogast. Iberogast has been around for years, initially in the IBS world and then the functional dyspepsia world, and now it's moving up into the GERD world. So it's just kind of moving its way up. And it's a concoction of 9 different herbs that has multiple kind of mechanisms of action. So herbally, I would use Iberogast both for IBS and FD. So those are sort of my non-pharmacologic tips of the trade.
Any experience with fermented foods and probiotics?
I think that's early. Stanford has a whole group that's looking at plant-based and fermented foods, and fermented food does change the microbiome and it increases the diversity. The challenge is that fermented foods are difficult to be tolerated by patients with IBS because of the gas formation. So I think we still need to understand what the manipulation of the microbiome that does to symptoms. So I think it's intriguing, but too early to tell.
Dr. Nguyen, Center.
Oh, hi, Kevin with Kaiser Orange Study. So it's interesting on that study that you mentioned about the increase in eosinophils and mast cells for patients with functional dyspepsia. I mean, many times you do an EGD for patient with those symptoms, and I mean, oftentimes we do random biopsy for celiac as well. Would you recommend just to do ask the pathologist, or maybe when you don't see anything abnormal endoscopically, just to look for evidence of eosinophils and mast cells in patients with quote unquote functional symptoms? And then what is the cutoff that you consider pathologic? So how can you differentiate eosinophilic enteritis from quote unquote functional dyspepsia that would guide your treatment into an antihistamine base?
So that's the challenge there, because we're seeing data on like the EGID, so the eosinophilic gastrointestinal disorders, but what's the cutoff? Like for EOE, we have better data on cutoffs. We don't have great data for mast cells. For eosinophils, we're thinking 35, but again, it's hard. There's such a wide overlap, and there have been a number of studies looking at mast cells in healthy controls, in functional dyspepsia, in mast cell activation disorder, and mastocytosis, hereditary alpha tryptosemia. And when you look at where those overlaps are, it's hard to draw a cutoff. So many pathology departments, including our own, refuse to count mast cells because they don't know what to do with them.
And I'd say it's kind of interesting that the interest in this and the tally study showed up right around the same time as we had the availability of a lot of biologic therapy for eosinophilic disorders. So there may be, different agendas going on, and I think it's still very much in progress.
It's definitely in progress, but it may link, and I think this is where we look at the subsets of patients, right? Because we know that patients with atopic disorders like asthma, eczema are more likely to have DGBIs, IBS, and FD than those without. So that data has been around for about a decade now. And so, so there is some like kind of, I think of it like mucosal immune dysfunction, but the question is how, how do we make those diagnoses? What are the cutoffs?
I'd say, but interestingly, those people are on antihistamines, steroids, other drugs, mast cell stabilizers, and yet they still have IBS. So long way to go, but yes, sir.
Just an observation. I'm going to retire next year, so I've been a gastroenterologist for 40 years. And one thing I've noticed over the last several decades, and this goes to a lecture that Ravi Chopra gave us here at this conference about leadership. People love leadership. They really do. And it turns out to be one of the rarest of human qualities. It's amazing how many doctors give up medical leadership in their relationship with their patients. It's unbelievable. The idea that their opinion is equal to yours is ludicrous, and don't put up with it. Everyone in this room is really smart, okay? We're incredibly well trained. We've been out there for 10, 15, 20 years. We've learned an amazing amount. And patients come in with these crazy ideas because they read 2 articles on the internet, and they think that their opinion equals yours. And the great thing about being an older physician, I can hear patients telling me, and I look at them and say, that's bullshit. You are delusional. I'm your doctor. I know what I'm doing. And yeah, okay, you have an opinion. It just happens to be wrong. And we did this, listen to this COVID bullshit and listen to the presidential election bullshit, okay? Take medical leadership in your relationship with the patient. And if they have some crazy ideas, you say, look, I'm not the doctor for you. I'm not your friend, okay? I'm your doctor. Go get another doctor. I'm not the guy. And so I'd say that's my advice after 40 years.
Thank you very much. And thank our new leaders here for that presentation. We're going to reconvene at 10:20 and learn about the hepatocyte. So we'll see you then.